Hello everyone, and welcome to Health for Niger podcast. My name is Dr. Ngozi Onoha, and today I have an incredible guest. Join me in welcoming Dr. Mark. She is a cardiologist. So today she's going to be talking about menopause and heart health. Thank you so much, Dr. Mark, for coming on the show. And tell me a little bit about you and what you do, and then we can dive into this very important topic.
Thank you so much, Dr. Ngozi, for having me on your podcast. It's a pleasure. I am, as I was introduced, I'm a general cardiologist or a non-invasive cardiologist. I don't perform any procedures. I take care of general patients, and I have some expertise in imaging. My interests in cardiology are primarily prevention, how to prevent heart disease, also working with bridging the gap in health inequities, as well as in cardiovascular women's health.
And I think that's a great topic because, as we know, Black and Brown people are disproportionately affected by heart disease, and in particular, Black women. So this is really fantastic to have you on this podcast today. So, I know menopause is something that all women are going to go through. And typically, for people who are not aware what menopause is, it's cessation of menstrual periods that kind of occurs about the age of 51. And how you know a woman has been in menopause is that she's had 12 months of no menstrual cycle. And it's caused by just a failure of the ovaries. And with that, they drop the women and don't have estrogen. And so they now develop these menopausal symptoms, which could include hot flashes, the sweats, the anxiety, sleep problems, and just so many things. So I'm glad that you're here so you can really explain to us how this menopause affects women's health. So one of the questions that I actually have for you is why does cardiovascular risk increase in postmenopausal women?
Right, so you nailed it right on the head. It's the role of estrogen. Estrogen is actually protective against cardiovascular disease. It promotes vasodilation, meaning that the blood vessels are a little bit bigger. When the blood vessels are bigger or dilated, your blood pressure essentially is lower. All right, so we know high blood pressure can lead to heart disease. And so estrogen, in a way, actually helps to lower the blood pressure by letting your blood vessels be vasodilated. It's also involved in the kidney pathway in regulating the blood pressure. Okay, it helps to inhibit the pathway in the kidneys that leads to high blood pressure. So that's another way that it's very protective against cardiovascular disease. And then it also regulates inflammation in the body. And so once you're postmenopausal and your estrogen levels fall off, that is when we start to see you lose the protection and your cardiovascular risk starts to increase.
Okay, that's very interesting because I know quite a few of my friends who developed high blood pressure as they got into menopause. Even just before going into menopause, I observed that a lot of women before, sort of in their late 40s, a lot of women are taking blood pressure medications.
Mm-hmm.
Where nothing has really changed in terms of their lifestyle. They're still eating the same, they still have the same activity level, but for some reason, a lot of them are now taking blood pressure medications.
Yeah, some of it can be linked to the decrease in the estrogen levels as to why the blood pressure around that time starts to go up. You have a change in the composition of your body fat where it lays more in the abdomen. So that increase of fat in the adipose tissue, or fat in the abdomen, leads to increased marked inflammation, which then leads to what we call metabolic syndrome, which sets off a cascade that leads to diabetes, hypertension. Also, the dropping off of the estrogen levels leads to increased cholesterol levels as well. So we touched upon high blood pressure, but it also then starts to increase your cholesterol. So same way that you start seeing the blood pressure go up, all of a sudden you go from someone that's normal cholesterol to elevated cholesterol levels in that peri or postmenopausal state.
Okay. So, and then that's also interesting because I've observed that too.
Mm-hmm.
Um, Also in myself, I've noticed cholesterol has gone up over the years. And I think it would be nice also for you to educate us on why Black women are disproportionately affected by heart disease. We're seeing that a lot. What can we do as Black women to reduce this issue of this health disparity when it comes to heart health care and
Right.
and the risk, health risk.
Got it. So some of it may have to do with socioeconomic status, just by where you live affects your cardiovascular risk. The food that you have access to is not necessarily the healthiest food that's available. There may be more Black women in the workforce, okay, or single caring for children. So there's also a role of stress, less hours available to make healthy or to form healthy habits, period. You may not be exercising as much, and therefore you end up gaining weight. And as I mentioned, that weight and abdominal fat increases your cardiovascular risk. So there's definitely a huge component of a socioeconomic status, where you live, where we tend, Black people or Black particular tend to live more so in the inner cities where there are food deserts. They don't have access to healthy organic food, and in many cases, if they have access to it, it's very expensive. They don't have the means to afford it. So what you put in your, is what you are is what you eat, is a famous statement, and
Right.
it's exactly right. And then I talked about stress. Stress leads to high blood pressure. We don't tend to treat mental disease within the Black community. And so that is a huge component as well. And then the last is probably hereditary influence. Okay, genetics play a huge role. And I do believe that there's genetic interplay going on. So you kind of have the double whammy. You have maybe a poor socioeconomic status, plus stress, plus this hereditary interplay that increases your risk. And when the disease is there, it gets underdiagnosed and undertreated.
Okay.
Right.
So, and then, access to care. So you touched on that as well. So women are busy and they don't have time to attend doctor's appointments because they're working, taking care of the household. So those all come into play quite
Correct.
significantly. So lately, I've been reading so much on the news about hormone replacement therapy. At some point, I believe almost 20 years ago, HRT got a really bad rap at the time. There was a study that came out, and then women were just flinging out their pills and throwing them out. But looks like the hormone replacement therapy as management of menopause is now coming back. So can you just comment briefly on what the role of HRT is in the heart health of women in menopause?
Right. Unfortunately, there still is no role in decreasing your cardiovascular risk by taking estrogen replacement therapy or hormonal replacement therapy. They did that large study that showed there was no cardiovascular benefit, and if anything, women that were on estrogen did worse. So there's no role. We don't recommend it. However, for treatment of symptoms, you can use these drugs, but we recommend it being used solely for treatment of symptoms and for short term.
Okay.
Okay. And so if you are very symptomatic going through menopause, certainly these drugs can help you, but you will take it knowing that it's not going to be helping your heart and you're taking it just for the duration of symptoms. We don't want you on these drugs long term.
So when you say heart symptoms, because I know quite a few women who've had the vasomotor symptoms of menopause, the hot flashes that comes with these profuse sweating episodes and just feeling hot. And then along with that hot flash comes the palpitations. So I've observed a few women in my circle who've talked about going on the hormone replacement therapy for menopause and having significant reduction in those hot flashes
Mm-hmm.
and actually feeling much better on that on the HRT and actually not having those fast heartbeats and those drenching night sweats that the women complain of, the brain fog. So you sometimes will find women who have been taking HRT for a while are very reluctant to actually stop taking it because they actually feel so much better on it.
Mm-hmm.
So,
Yeah, a lot of it is, at the end of the day, the symptoms that they have, they're not life-threatening, right? And so you kind of have to assess the woman and her individual risk of having heart disease and how bad her symptoms are and make a decision, a joint decision with the patient and yourself, the physician, to really decide how important it is for her to not have the hot flashes. Although as uncomfortable as it may be, it's not something that's going to have you hospitalized on treatment for, and it has no long-term effects. And the same thing with the palpitations. I spend the majority of time reassuring patients that nothing is wrong with their heart. This is the normal physiologic response, normal response of the heart to what's going on, these changes in their body, and it's not harmful whatsoever. And so, again, you just have to kind of weigh the pros and cons and decide with the patient what's the wisest thing to do.
mhm. I've read somewhere that exercise, even before women go into menopause, is actually helpful because what exercise does, it exercise, it lowers the heart rate. And
Mm-hmm.
so you have that cardiac resilience, shall I call it? And so
Mm-hmm.
I've heard that women who exercise quite a bit uh, before they get into menopause actually do much better. And I don't know how true that is.
No,
Um,
I think they did look at women, and they compared those who were on a strict exercise diet regimen going through menopause and the women who were exercising and on a heart healthy diet overall did better. It lowered their cardiovascular risk as well. And so, yeah, I do agree that you should, just in general, regardless of menopause, we know
yeah.
having a healthy body weight, having a small waist or hip circumference, and eating low fat foods can improve your cardiovascular or improve your longevity. You can live longer and healthier. And so, yes, regardless of knowing you're going through menopause, those are things that you should be doing. But as women, maybe we need to be a little bit more strict in doing those things to reduce some of the complications that go along with menopause.
Okay. So we have a little bit of time. So I'm just going to ask you to just talk briefly about the kind of tests that a woman might have to evaluate for any kind of heart disease. Our audience is general, and I know we're having this discussion more like education. And, some people really sort of fear coming to the doctor when you say, oh, I want you to go see a cardiologist. And sometimes they are so scared, they don't know what to expect. A lot of them, get quite afraid to go see a cardiologist because they don't know what that entails. So can you just, for the benefit of the audience, just explain what to expect when someone, goes to a cardiologist? What kind of tests do you think that person may need to have, depending on their symptoms? They have palpitations or chest pain, for instance, sort of thing.
Right. So, as a preventative cardiologist, a lot of people come to me healthy. They don't have any symptoms, but they're concerned. They're 50, they have a family history. Their dad or their mom had a heart attack or stroke at a young age, and they just want to determine, what is their own individual risk. So during the office visit, I spent a lot of my time just collecting information and asking them questions. What's the family history? How was your pregnancy? Did you suffer from any cardiac complications in your pregnancy? Because that in itself also increases your risk. So when I say cardiac complications, did you have hypertension in pregnancy? Did you have preeclampsia, or they call it toxemia in pregnancy? Did you develop gestational diabetes in your pregnancy? These things your doctor should be asking you as a woman, because it will heighten my concern for you in the long term. The other thing I start to do is then I look at blood work. So if the blood work's not available, that's one of the first things I do. Look at blood work. I'll check your cholesterol. I want to see what your fasting blood sugar is. There is an inflammatory marker called the C-reactive protein, sometimes also known as a high sensitivity C-reactive protein, or the cardiac C-reactive protein is an inflammatory marker that, if elevated, increases your risk of cardiovascular disease. A deeper look at your cholesterol, I may check something called the lipoprotein A, which also you can have normal cholesterol levels, but this cholesterol component can be really elevated. It's usually inherited, and it may glean some idea of additional cardiovascular risk. So just by checking blood, it gives me a lot of information. Also in the exam, we're also going to be checking your height, your weight, your blood pressure, doing a cardiac exam, listening to your heart. Do I hear any extra heart sounds or murmurs? In your doctor's office, when you get an eye exam, they can look in the back of your eye and see certain changes related to your blood pressure, sugar levels, and also cholesterol deposition in your eye. So you can get a lot from a physical exam as well. Going beyond blood work and examining you and talking to you, there is a screening test out there that I use primarily in my younger patients, but it can be checked up until the age of 75, and it's called a calcium score. It is now more readily accessible to the community. The price point, about 125 US dollars for this test. So it's not terribly expensive, but certainly it may be cost prohibitive for some people. But many of my patients are able to get this without blinking their eye, because they think it's important and money well spent. So the calcium score is a CAT scan of the heart. It's multiple x-rays looking at the heart to see if there's calcium deposition on the arteries, which is a marker for plaque or hardening of the arteries. And then they quantify how much is there, 0 being none, all the way up into the 1,000 range, which would be considered severe. And then you can do some additional risk calculations, putting into everything that I mentioned, plus the calcium score, to assess your cardiovascular risk in like the next 10 years to determine if you're low risk, high risk, do we need to get you on medication. So that's the standard testing that I would do in a patient coming to me without symptoms. Now, if you're having symptoms, it's a different story. And it really depends on the symptoms and your physical exam, what I may do for you. Someone with palpitations, you may end up wearing a heart monitor, and that's some electrodes on your chest that assess your heart rhythm to determine if you're having any life-threatening heart rhythm issue. If you're having chest pain, depending on the severity, usually do some form of stress testing. Okay. Shortness of breath, you can get a heart monitor, stress testing, and you may also get an echo, which is an ultrasound of the heart to look for a structural problem in the heart, like a leaky valve or a narrowed heart valve.
Okay. So that was really good information. I think also, when people hear that stress test, they get scared too. That
Yeah.
stress test is quite, and all it is really running like on a treadmill. So some people, they hear stress test and they are so petrified of this stress test, but it's not difficult. It's just running on a treadmill, right? And then those that can't run, they get the medications to help increase the heart rate for the scans, right? So, yeah. So
Yeah.
this has been, yeah,
Yeah,
go ahead.
nothing to be too fearful about, but I think people just hear from the grapevine. My friend had it, and one, either they felt very tired, fatigued after they ran on the treadmill, or the chemical agent we do to induce stress, it can cause some people to have profound symptoms. So I don't want to, poo-poo that,
Right,
for
right,
lack of a
right,
better
right.
term, but it's a small minority of people. The symptoms are usually very transient, and we get a lot of important information. So I would not let the fear drive not getting the stress test.
Yeah, I think that fear too. And then people fear the unknown, and then they think, oh, it ain't broke. Why? Oh, I don't want to go see cardiology. It ain't broke. But,
Yeah.
the issue we have, especially in some of our African diaspora communities, is we have a lot of high cholesterol levels. I don't know, the diet is just so rich. And the calories are more than people are used to, coming to America, and all of a sudden you have a supersized meal. And so we see a lot of this high cholesterol in the African diaspora communities. And so I think having this cardiac evaluation is important. That preventative evaluation is very important, especially when people have these risk factors. So, and more so with women, because they are disproportionately affected because of so many of the social determinants of health that you talked about. So I think we need to pay a little more attention to our health as women, our heart health. And, I want to thank you so much for taking time uh, from your busy schedule. I know we've been trying to schedule this for quite a while, and
Yeah.
I'm so glad that finally we were able to have this conversation. More so, I believe it's Women's History Month this
Yes,
month,
it is.
something like
It is.
so. Yeah, so month of March, and so
So the
this.
timing was actually perfect. It was
Yes,
right on time.
yes, yes, yes. And it's amazing because I want to thank you so much, honestly, because there aren't a lot of Black female cardiologists who are doing what you're doing. And so you being here is not just important to women's health, but also to the women who are watching and may be inspired to become a cardiologist because they've seen you and they've heard you speak. So your presence here is so important. And I want to thank you so much for coming on this program.
Thank you so much, Dr. Ngozi. Much appreciated calling me anytime.
Yes, thank you. And have a wonderful day. So is there any before you head out, is there just one little pearl of wisdom that you want to share with the general audience? It might be just some health or wellness tip or just something inspirational, or just something off the top of off the top of your head. Is there anything you may want to share?
Yeah, so I would say there's a lot of fear within the Black African American community and the medical system, but there are several doctors, not just Black, but brown and white, Asian, uh, that are thoughtful and really do care about their overall patients. And you really need to search out for a good doctor-patient relationship. If you don't feel comfortable to ask questions to your doctor, if you ask questions, they don't give you a proper answer, you find someone else, okay?
Absolutely.
I think within our community, we're kind of taught the doctor said something, so I need to listen and just do it. You come home, you don't understand why you're doing X, Y, and Z. You feel scared to ask questions. That's not the right doctor for you. And unfortunately, if you're in a rural area, you may not have a choice. That might be what's available to you. But if you're in the inner city, there's plenty of doctors, right? And you should really shop around and find a physician who you feel is compassionate, is open to answering your questions, and taking the extra steps to learn about you, ask you how is your day, ask you about your job. All of these things help me in assessing my patient and figuring out what's important to them. And I think I didn't touch upon that, but I think sometimes we are a little harmful on ourselves because we accept what is given to us. And I think we need to just stop accepting. And if something feels off, something feels wrong, ask questions. If they don't want to answer your questions, or they turn a blank eye, find someone else, ask for someone else to take care of you. You have that right. There's power in your hands. You are a consumer paying for services. Think of it that way, and make sure you're happy with the service you're getting. Okay, so you do need to empower yourself in medicine to really improve your outcomes. It kind of starts here with us as a patient to advocate more for ourselves.
Absolutely. I think you're so on point with what you've just said. The patient autonomy is very important.
Yes.
That was good, and I'm sure it's going to empower people. And that's what we do. Health for Nigeria provides health information and empowerment for people to improve their health. So thank you again for coming on the show. I'm going to end the recording now. Bye.
Bye bye. Take care.